Without much further ado, here our first speaker is Dr. Edwin Lee, who I think like probably 99% of you know. He's very active with AMMG. He's the assistant professor of internal medicine at the University of Central Florida here in Orlando. He has an Orlando practice in wellness, preventive medicine, and regenerative medicine. He is board certified in endocrinology. He's an expert in diabetes, endocrinology, and internal medicine. He's been the author of many several books and many articles, and I think you're going to enjoy him as a speaker. He's really an outstanding speaker and a lot of fun to listen to. Dr. Lee?
All right, good morning. It's early Saturday morning, so I'm going to hopefully entertain you, and you'll learn a lot about peptides. Peptide therapy has really changed my practice, and I just want you to kind of take home basically 3 peptides, because I've been to several talks where they've talked about 10, 12, 14 peptides, and after the lecture you get all confused. So I want to disclose I have actually nothing to disclose. And let me just start off with this slide. I remember in high school, I was kind of like the dork and kind of a geek, so there was always these attractive women in my grade, and I was too shy to ask anyone for the prom. But I did go back to the 10th year reunion, and I remember these women were like really gorgeous, and 10 years later, I was just totally shocked. So actually, what's even more funny is that I gave those 2 slides to, I volunteer at my kids' school, elementary and middle school, and they just not one laughter, because they think that in 10 years everyone's like this. And it's like, oh wow, I got to stick to farting or making some special noise. But anyway, the aging process has always fascinated me, because at that 10th year high school reunion, it's like, I'm thinking, why did this gorgeous woman really accelerate the aging process? And it took me a while to figure out, it's everything that you learn during the conference. It's basically chronic inflammation, oxidative stress, free radicals, the liver not detoxing, nutritional deficiencies, excessive stress, but also hormones. So I want to focus on today's majority talk is on growth hormone, and I consider myself an expert in growth hormone. I've been prescribing it for over 20 years. And growth hormone is a 191 amino acid or a protein that our pituitary secretes, or somatotropes. And growth hormone is also known as somatotropin. So if you read the literature, sometimes it doesn't say growth hormone, it's somatotropin. And it's abbreviated universally as GH. And it was discovered by my uncle, actually, Dr. Lee. No, just kidding. In 1955. Actually, Bruce Lee is really my uncle. So in 1971, Dr. Lee determined the structure of human growth hormone. So from that time on, the early 70s, growth hormone basically kind of has grown. So before 1970s, growth hormone deficiency was really, it's tough, and especially for young boys, because they get picked on, their self-esteem is low, and I always found it exciting to treat. I was kind of fortunate during my training program to be taught on how to diagnose growth hormone deficiency in adolescents. So I have kind of like a pediatric adult endocrine background here just for growth hormone. And the thing is that it's just truly amazing when you can see some especially young boys that they're really failing classes, they're getting picked on, low self-esteem, and when they start growing, they just blossom, and it's truly amazing. And I think it was probably 15 years ago, I just remember getting denied in the kid actually failed the stimulation test, so he qualified for growth hormone, but his insurance basically denied it, and I just was so frustrated. I saw the writing on the wall, so I got to get out of conventional medicine. So let's go to the growth hormone axis. So it starts really from the hypothalamic area. It releases growth hormone releasing hormone. That stimulates the pituitary to release growth hormone. That gets to the basically your liver to secrete IGF-1, and IGF-1 basically can turn off basically the hypothalamic and the pituitary area. Now there's other peptides or hormones or also proteins that are involved in terms of regulating, and the take-home message is look at ghrelin. Ghrelin is really an important hormone, and ghrelin actually stimulates the growth hormone release. So on the stimulatory side, you can see that it's growth hormone releasing hormone, exercise, increase in ghrelin. So ghrelin is the hunger hormone. So if you practice intermittent fasting, skip several dinners, your growth hormone is probably going to be released. Increase in amino acids, decrease in blood glucose, and decrease in fatty acids. So on the other side is inhibitory, but these are the classic stimulatory and inhibitory for growth hormone release. So growth hormone deficiency, in the classic sense, the number one cause for childhood and is really pituitary tumors or brain tumors that impinge on the pituitary gland. You can have a mutation of growth hormone releasing hormone. You can have a congenital disorder, Prader-Willi syndrome or Turner syndrome. Chronic renal failure, that is an indication before transplant to be, especially in children, to use growth hormone. Radiation damage to the pituitary or hypothalamic, and Sheehan syndrome. So I have several women who've basically got Sheehan syndrome, and they require, as an adult, growth hormone replacement. But I think what's more on the rise, you can see ischemia and stroke, but it's also traumatic brain injury. And I know Dr. Gordon gave, to me, it's amazing, 8-hour talk on traumatic brain injury. I once gave a 4-hour talk, and I was mentally exhausted after 4 hours. I don't know how he did it for 8 hours, but anyway, the thing is that I remember after giving 4 hours of talk to this small little seminar, the next question goes, can you speak more? It's like, no, I'm going to the airport, getting a drink, I'm going back home. But anyway, there's a lot of benefits with growth hormone. And anyway, you have to diagnose it if you're going to use recombinant human growth hormone. So you can screen with IGF-1 or IGF binding protein 3. That's the one that carries the IGF-1. And insurance companies will require, generally they required only one test. Now some insurance companies are using 2 tests. So you should use insulin tolerance test and with the glucagon stimulation test. And in addition, you need an MRI to confirm, to make sure you don't have a tumor. You don't want to give anyone recombinant growth hormone if they have a tumor. So synthetic growth hormone is very expensive, and for some of my patients that's on it, they do pay out of pocket, and some of my patients are paying up to $2,000 a month on recombinant growth hormone for year after year after year. It's not everyone, that's the most expensive. But so anyway, recombinant growth hormone is a 22 kilodalton protein. Remember, 191 amino acid. There are different isomers of growth hormone, and there is a new one called growth hormone 2. It's a 20 kilodalton, different from growth hormone 1, which is 22 kilodalton. So recombinant growth hormone is growth hormone 1, which is the 22 kilodalton. And the difference between growth hormone 2 and growth hormone 1 is that it's an isomer of it, and there's some amino acids that are deficient or been deleted from, you can see E32 to Q46. So the thing is that growth hormone 2 has been shown to elevate IGF-1. But there are also 4 more isomers of growth hormone 2. So the pituitary actually secretes 5 growth hormones, not just 1, it's 5. So this is kind of exciting, because if you can stimulate your own pituitary to release 5 growth hormone, I think that's better than just taking just recombinant growth hormone, which is one version of it. So let's move on to peptides. Just raise your hand if you've been using peptide therapy. Okay, few, not many. So peptides has been around in some countries, like in Europe and even in Russia. They've been using it for close to 50 years. In Australia, about 20, 30 years. The U.S. is kind of far behind. But anyway, peptides are really just a combination of amino acids, and if the peptide is over a certain length, then it's called a protein. But the protein and peptide is a little different because how the structure is and the 3D dimension of it. So peptides are, I've heard out, let's say, at several conferences, it's basically 100 amino acids, but the literature really shows it's 50 amino acids or less. So anything over 50 amino acid is basically protein. So anyway, that's debatable, but the literature that I've read is 50 amino acids or less. So there's a peptide bond. So when you have an amino acid connected to another amino acid, you form a peptide bond. So how many proteins are in us? So it's estimated we have 2 million different types of proteins coded by about 20 to 25,000 of our genes. That's just an estimate. But the field of research that looks at basically and categorizes proteins in the human body is called proteomics, and that's a huge science. And they estimate that it's about 50,000. But according to the human proteome map, with 17,294 genes identified, and only 85% of that actually is known to basically code for a protein, they've discovered identified 30,000 proteins. So if you look at peptides or small proteins, that's how I explain it to my patients. It's almost 300,000 peptides in our body. So we have peptides or smaller proteins circulating in our body all day long. So I think for a lot of people, the consumers have heard about peptides. It's been in skincare products for some time. So it's usually the women in my practice, they get the peptides. It's the guys who've most of them, they've never heard of it. So how can like a skincare product that has peptide help? And I was curious about it. So there's a tripeptide, 3 amino acids. It's glycine, histidine, and lysine, and it can stimulate collagen synthesis. So you just have to have the delivery system, and they've worked on some nanomolar concentrations for it to work. So now, this is interesting because not many people know that certain hormones are actually peptides. And classic ones are your prolactin, which basically helps with production of milk. ACTH basically can stimulate cortisol. You can see calcitonin, growth hormone releasing hormone, which is a 40 amino acid. There's PTH, oxytocin. ADH and natriuretic hormone there. So this, you guys can see, I guess this is, anyway, I guess my previous slides I had it that I can just click on, but there's an amazing antioxidant that's in our body that's really important in detoxification. It also helps with basically repairing and helping with DNA synthesis, and that's called glutathione. So glutathione is really a 3 amino acid peptide. So it's glutamate, cysteine, and cis-glycine. So what's the difference between a peptide action and also a classic hormone? Well, peptides, think of it as like, it's like a domino. It actually sends a signal on the outside of the cell. You get like a domino effect, and then it turns on your DNA to basically make that protein. So that's the way, if you want to think about it, that's how the peptide works. Whereas the steroid hormone action, it's like a key and lock. That hormone is like a key. It has to go into the nucleus to basically bind onto the DNA to basically turn on basically synthesis to make a protein. So you can see that it's like a key and lock versus a domino effect. So growth hormone releasing hormone is a peptide. It's a 44 amino acid, and there were 3 scientists, and the woman here, small print, I think Dr. Yarlow, she won half the prize. She was the second woman to ever win a Nobel Prize in science. And anyway, she discovered really interesting. She was a physicist and kind of went through college during the war, and she kind of got some grants because there weren't many men around. They were serving the war, so she actually hooked up to a lot of scientists, and she actually discovered the RAI, a radioimmunoassay. So most of the hormones that we've been looking at and monitoring, it's actually through her. Anyway, they all 3 got the prize for the growth hormone releasing hormone. So you could use, if you can use the growth hormone releasing hormone, I think that's a better way than FYI recombinant human growth hormone, and I think that's really going to change your practice, and also I've been actually trying to encourage my patients to use a more natural way versus recombinant human growth hormone. So remember, the pituitary secretes 5 different growth hormones, so when you take recombinant growth hormone, it's only one version. It's the majority of the version, but if you can release all 5, you're going to get a better effect. So growth hormone releasing hormone or growth hormone releasing peptide is more physiologic than basically recombinant growth hormone. And you need basically, this is the key point. If you had damage to the pituitary, it may not work. That's the thing. So you need a functioning pituitary. So growth hormone releasing hormone is basically secreted in pulsatile, so you get the growth hormone release. So the highest release is really during your REM sleep, and it's like middle of the morning, 1 a.m. to 3 a.m. So it's hard for your patients to actually monitor their growth hormone. I mean, because you have to do it in a lab or not a lab, at a university setting where a research setting where they put a catheter in and they monitor your blood throughout the entire day and nighttime. So this is an interesting little fact. Andre the Giant, he actually had acromegaly, but it wasn't from the pituitary. It was actually, he had an ectopic secretion of growth hormone releasing hormone. And he basically had pulsatile growth hormone secretion. So even though he was acromegalic, he still had the pulsatile secretion. So growth hormone releasing hormone basically is a 44 amino acid, but what they discovered is the first 129 is part of the amino acid is the active part. So there was one of the Nobel Prize laureate, he basically asked one of his students, he goes, let's see if you can eliminate one amino acid at a time to see if it's still active. And so the student basically just deleted one amino acid at a time and then discovered you need the first 129 to basically make it active. So growth hormone releasing hormone basically is degraded by DBP4, and growth hormone releasing hormone's very short half-life. It's about 7 minutes, whereas growth hormone has a half-life of 12 minutes. So the first, I wouldn't say first, but anyway, what's used in the U.S. is a lot, and I've tried this. I always pronounce it wrong. Semirelin, Semirelin is basically a synthetic version of the 129 version of growth hormone releasing hormone. It was actually FDA approved for injections and diagnosis of treatment of growth hormone deficiency in children. And 16 children with short stature were treated with this modified growth hormone releasing hormone, and for 9 months, and they showed a significant improvement in height. So they were using 30 units per kilogram per day. So Semirelin basically is no longer commercially available, but it is, you can get it compounded. The dosage, is, you can see, is 0.2 to 0.3 micrograms of Semirelin at bedtime. There are some side effects, and I have some patients who've done very well with it. But I've tried it multiple times, and I've really hadn't had much success with it. I've had a lot of problems complaining of welts and a lot of reaction to the skin. But I mean, for some people it works. So in the U.S., it's kind of more the Semirelin, but in Australia, which is almost the same size as the United States here, they've been using other peptides to release growth hormone, and I think they're kind of the leaders out there because they've been using it for 20 plus years. And they really like the peptide called CJC 1295. And peptides have these funny names. They have all these, it's like alphabet soup with numbers. So it's when you go to these peptide conferences, it's like Greek. But anyway, another name for CJC 1295 you may see in the literature is the modified or MOD GRF 129. So the CJC 1295 is also a modified part of growth hormone releasing hormone. It's the exact same 1 to 29 amino acid, and basically it has a half-life of 30 minutes. The CJ 1295, they have 2 types of, they can basically use a drug affinity complex to extend the half-life to 6 days. Or it can be without DAC. So we call 1295 without DAC or without the drug affinity complex, or you can have it with the drug affinity complex that basically can sustain it to 6 days. Semirelin has a short half-life of 10 minutes. So remember, CJC 1295 can be compounded with DAC or without DAC. Generally, it's what I use is without DAC, but CJC 1295 without DAC, you should use it at nighttime, and that's the best peak, is to use it at nighttime. So here's a study that shows that CJC with 1295, they're looking at different dosing in 24 healthy adults, and the higher dose you go, you can see that the higher release of IGF-1, no serious adverse effects. Here's another study showing a 20-minute blood sampling throughout the night in 20 to 40-year-olds, and they noticed that you can see that they had still the pulsatile secretion of growth hormone. So just to take away a message on this is that it still preserves the pulsatile secretion through the pituitary. What is really amazing is I have several patients who use the CJC 1295, and one of the benefits is they sleep really amazing. They sometimes say, hey, Doc, I normally sleep 2-3 hours. Now with this, I sleep 6 hours straight. I have one patient who actually got off his Ambien, who's been on it for 10 years, and that's very difficult to get off Ambien for 10 years. And he goes, I sleep like a baby with the CJC. So anyway, it's been shown that CJC has the ability to promote your REM sleep there. So there was a study. So CJC was used in a study, I think this is in Argentina, and they wanted to look for HIV patients with lipodystrophy, and this is in July of 2006. It's a 12-week study, and this one patient at week 11, he basically got his injection of CJC 1295 DAC, and then later basically had an acute MI and passed away. So currently there's no evidence that shows that it's cardiotoxic, and the attending physician basically commented that it most likely had asymptomatic coronary artery disease, and basically his plaque ruptured and caused an acute infarction or occlusion. So FYI, I do see people, and I have had patients, and I'm sure it's in your practice, they've been very healthy. They're like the picture of great health, but they have a lot of plaque, and it ruptures, and boom, you know, it goes down the left main, and it's the widowmaker. They have an acute occlusion, and they pass away. So the thing is that, you know, could this be coincidental? I think so. I mean, I've been in contact with several doctors in Australia who's been using it for 20 plus years. They've never seen this happen. So growth hormone releasing peptides since 1984. There's others, and there's a lot of them. Trust me, I was debating like how much information do I put on. I'll mention about growth hormone releasing peptide 6. It's 6 amino acids discovered in 1984. And apparently this was the first growth hormone releasing peptide discovered. So growth hormone releasing hormone, basically there's a receptor. It's your growth hormone releasing hormone receptor, and it basically increases cyclic AMP. But there's another receptor on the pituitary, and they didn't really know exactly what it was, but they noticed that with growth hormone releasing peptide 6, it actually did not go where normal growth hormone releasing hormone goes. It goes to a different receptor in the pituitary, and they eventually figured out what that receptor was. And activation of that receptor actually releases calcium. So increase of cyclic AMP and calcium in the pituitary shuts down basically somatostatin. Reducing somatostatin increases the release of growth hormone. So it's a two novel approach to basically increase growth hormone. So it turns out that receptor is actually the ghrelin receptor in the pituitary. And so you have two mechanisms in terms of releasing growth hormone. You have the classic receptor, the growth hormone releasing hormone receptor, and then you have the ghrelin receptor. So anyway, if you actually combine it, you're going to see actually they work synergistically. So I was going to go through all of these, but it's just too overwhelming. So I just picked really, well, I'm going to pick this one here, which is called ipamorelin. And ipamorelin is considered a third generation of the growth hormone releasing peptide. It has only 5 amino acids. And it increases growth hormone via the ghrelin receptor or the growth hormone stimulating receptor, GHS receptor. So, ipamorelin actually was discovered by a pharmaceutical company, Novo Nordisk, and there are a lot of pharmaceutical companies that have been really into this in the 80s. They put millions of dollars, probably billions of dollars into this. So anyway, they basically discovered that ipamorelin basically can release growth hormone. And the third generation of these growth hormone releasing peptides does not raise cortisol, prolactin, or aldosterone versus the first generation of growth hormone releasing peptides. So ipamorelin is basically there's pharmacodynamic studies, pharmacokinetic studies, and so they noted that escalating doses, and they noticed that the half-life is 2 hours, and the peak of growth hormone was within 45 minutes. So again, to show you that, which is so on your right or on your left, on one side is the classic growth hormone releasing hormone, and it increases cyclic AMP, but ipamorelin actually works on the ghrelin receptor and increases calcium. Remember, it lowers somatostatin to release growth hormone release. So why didn't Novo Nordisk basically continue using ipamorelin? Well, they were really interested in basically ileus, post-operative ileus. It was very popular. I mean, I'm sure I remember when I did my rotations through anyway, medicine, and you would have a post-op patient. Ileus is, a big thing. And so the thing is, they did a study, phase 2 randomized study looking at ghrelin receptor agonists. Remember, ipamorelin activates the ghrelin receptor for the treatment of postoperative ileus following abdominal surgery. And ipamorelin was basically discontinued due to the lack of efficacy, but very well tolerated. So the action of CJC by adding ipamorelin, this is why in Australia they like this. It's a dual mechanism approach. And you can see that when you combine it, you actually have a higher release of growth hormone. So CJC 1295 with ipamorelin without DAC. Both are formulated at 2,000 micrograms per ml, and you can basically you have them start at 5 units with an insulin syringe at bedtime, Monday through Friday. And this is really important. I tell all my patients, especially my male patients, because once they're really excited about to use this, I know what they want to do. They're going to do it every day, every night. And it's like, no, you got to cycle it. You got to just basically give your pituitary a rest for at least 2 days. So you take it at nighttime, and I forgot about it. I remember I got a sample of it, and anyway, I injected it I try a lot of things in my office. So anyway, I'm like the guinea pig. Like when I make new IV nutrition, I always offer to my staff first. And I say, hey, I got this cool IV. It's going to do blah, blah, blah. And I go, who wants to be the first volunteer? And I have a small staff. I have 4 people. And every time I do that, they always look at their shoes. Like there's like something on their shoe. Like, it's like, what's on your shoes? Is it gum? So no, I mean, I was like, okay, I'll just do it. So, and then I tell them, see, I'm alive. So, I totally forgot that when you inject CJC 1295 with ipamorelin, you're going to get an immediate, like a niacin flush from your neck up. It's like you get red and hot, and it only lasts 5 to 10 minutes. And I remember injecting it. It was like, whoa, wow, this is like a hot flash. This is terrible. But it soon faded, and I had a good night's sleep that night. And the thing is that, anyway, just inform that it's a good thing. And a lot of my patients feel like this is a good thing that's working. So flushing lasts 5 to 10 minutes, and you can go up to 10 units, and that's the most common dose is 10 units sub-Q on the insulin syringe at bedtime. So that's 200 micrograms. So there's something better. So that's the best. But the problem with this one is it's so popular that it's hard for me to even get. I'm on a waiting list to get it. So, but if you can get it, this is great. So which one is this? It's called Tesmorelin. And for the longest time, I always had trouble remembering this word. So I had to think of Tesla, and then from Tesla to Tesmorelin. So anyway, Tesmorelin was discovered by a Canadian pharmaceutical company. Basically, it's FDA approved for HIV lipodystrophy. And it's basically degraded by the DPP4 enzymes, and the half-life is 30 minutes, and growth hormone releasing half-life, remember, is 7 minutes. So this one's a 44 amino acids, similar to the length of growth hormone releasing hormone. There's a little different formulation to it. And this is, if you haven't worked with HIV patients, a lot of the medications that they're on, DDI and all these other medications that I crammed for my internal medicine recertification. They didn't even ask one question on HIV, but the thing is that in 2010, Tesmorelin basically was approved for HIV lipodystrophy. So there was a study at Harvard in healthy men, not in HIV patients. They used Tesmorelin 2 milligrams sub-Q once a day for 2 weeks. And they noticed that IGF-1 was increased by 182. Huge. I don't know if you ever used recombinant growth hormone. I don't see that. I mean, you got to use a lot. And sometimes I have patients that don't even respond to recombinant growth hormone. So it's been shown that it reduces triglycerides. It can reduce visceral adipose tissue. That's what it was used for the HIV lipodystrophy patients, because they had a lot of visceral fat. It reduces CIMT. It improves cognition. So I tell my patients, it does everything except it doesn't wash your car or wax it. I mean, it's like, I mean, who doesn't want to have better growth hormone, better IGF-1, and to have all these other effects? So tesamorelin is actually compounded, and they've actually taken out the mannitol. Anyway, this is the protocol. You use 1 milligram injected at bedtime. They recommend you take like 1 day off per week rather than 7 days a week, just to give the pituitary a break. Sometimes I tell my patients just take a Monday through Friday, take Saturday and Sunday off. And I have a lot of patients who love tesamorelin. It's just hard to get. And let me just tell you, the patients who've had, this is my experience, I've had a lot of patients on recombinant growth hormone. For those patients that have been on recombinant growth hormone for about a year or two, they usually can basically get on the peptides, whether it's CJC 1295 with hypermorelin, and their pituitary kicks back. For those patients who've been on recombinant growth hormone for 10 years or more, I think it's going to, after 6 months, I don't see any improvement. So their IGF does not improve, they don't feel it, and they want to get back on recombinant growth hormone. So it doesn't work for everyone. And there is a big debate. There was a conference just recently, and they were talking about, do you really need to monitor IGF-1? Because I'm going to tell you right away that even with CJC 1295, I have a lot of people who say, this is the best I've felt. This is FYI. They're generally my subset of male patients who work out into fitness. They go to the gym 5 days a week, and they feel super, they love it. Now, I have people who feel great, but their IGF-1 does not bump up. Does that mean that it's releasing 4 other growth hormones in the pituitary that we don't know how to measure? Another thing is that if they feel great, is it a placebo effect, or is it really working? And you know, I see people, they're losing body fat and they're feeling great. So it's a hard thing to say. So there's a debate whether you should follow IGF-1 in patients with these peptide therapy, because it could be frustrating. Now, I have women who take it and they go, Doc, if I take this, I look younger. If I don't take it, I look older. So, you know, it's all about, you know, increasing type 1 collagen. So this can help you on Monday when you get back into your practice, when it's your libido booster. And for men, it's very simple. They just need oxygen and a little testosterone, and they're ready to go. So they also need a pulse too. For women, it's a little different. You need sincerity, you need respect, you have to have integrity, you have to be honest, you have to open the door, you have to, you know, shine the seat. The full moon, so it's a little harder. So I have great results with this peptide, and anyway, it actually works in men and women, and this is basically a peptide that I'm going to talk to you about. But for libido to improve, it's very complicated. But there's nitric oxide. I know Dr. Bryan could talk to you, Dr. Nathan Bryan could talk to you forever about that. There's all these other hormones involved. But there's a peptide, it's called bremelanotide PT141. So I just say PT141. So I actually kind of coined it, we kind of coined it in our office, Magic Mojo. Once I put some signs in my office, ask about the Magic Mojo, and I don't know when my boys are coming to my office, but they're now 13 and 12. And they came in after I hanged the signs, and they don't come to the office a lot, but they came in and they saw the sign and they go, "Daddy, what is mojo?" And they go, "I think I need the magic mojo." So anyway, bremelanotide is a peptide that activates the endogenous pathways in sexual response. And there's an aphrodisiac area called the amygdala. And so he bypasses that complicated circle, goes to the brain. And they've noticed studies, here's a randomized double-blind placebo-controlled study, 342 married couples. And they gave them 10 milligrams as an intranasal spray, 45 minutes to 2 hours before the event. And anyway, they noticed that they were very, very happy and they had minor side effects. So FYI, there's another study in premenopausal women with sexual disorder, and in 18 women they use an intranasal dose of 20 milligrams, and more women reported moderate or high sexual desire following treatment. It also works in men, phenomenal. So I think I have a study that, I think it's right after here, but you can see that, let me see, no. There was a study in men that failed, it's not in this slide deck, with sildenafil. So these are men with ED issues with sildenafil, and they've noticed that in that group of population, basically it improved. So anyway, there's many different protocols. The problem is you don't know when it's going to kick in. So I tell them, take it early in the morning, and it may kick in 6 hours. If it is, text your husband. It may kick in 8 hours, 10 hours, 12 hours. Pay attention. Don't take it at night because it'll probably work middle of the night and you'll be asleep. So you take it early in the morning, figure out when it works, and then you can time it. Some guys say it's a 7.5 hours, they're ready to party, and other people say it's 4 hours, some people say 8 hours. So it all varies. It's one of those things that you don't know when it's going to work. And we have a lot of people, I don't really hear all the stories at the front desk, but I have a lot of returning patients who they talk to my staff about everything. So anyway, you got to be careful when you mix it with the PD5 inhibitors because you can have, for men, because they can basically, you can have prolonged erections for more than 4 hours, so which is not good. So that's, you got to be careful with that. But this is very simple. You can name it whatever you want in your office, but if you have kids, be careful. So peptides are available in the U.S. now, and there's a lot of peptide websites out there. I would recommend to be very careful. I tell my patients you can Google it, you can get it, but the problem is what do you get? And a lot of these peptide stores in the that's on the web, they're really unregulated, and you really don't know what you get. So they may have 10% of the peptide in there, they may have 0%. I mean, that's the thing. So you want to find a reputable company. So remember, peptides work a little differently. It's like a domino effect. It activates inside the cell, and it's in a way pleiotropic. So the three peptides I just remember, there's CJC 1295 with hypermorelin. Use that Monday through Friday at bedtime. And you can start with 5 units and titrate to 10. Sub-Q, there's tesmorelin, which is, I think, great, but it's hard to get. And then there's bremelanotide PT141. So I'm going to open to, if you have any questions, actually, I think I'm out of time. One or two questions. If not, yes. You'll be next, yes. What? I'm sorry.
Can you come to the mic?
Yeah, do you want to ask a question?
Thanks for the great lecture. These sound like great substances. I'm not using any peptides, but medical legal perspective on CJC with hypermorelin. Is that FDA approved for anything at all? And using these substances, I feel like we're at risk at least the tesmorelin sounds like it's FDA approved for something. It's being used in this country.
Yeah, there are a lot of the FDA approved medications, let's say for metformin, for diabetes, but you can use it off-label for pre-diabetes. You can use it for many other things. So in medicine, we do. It's up to you how you want to use this. This is not. It's a peptide. The FDA is kind of flying under. I think they're aware about this, but the thing is, there's no FDA approval for any of this. If it is, it's going to become a drug. But the thing is, it's available online, and a lot of people have been using it for 30 plus years. So FYI, it's anyway, that's the short answer to that. So.
All right, thank you.
Sure.
Yeah, I have two questions. It was a great talk, though. Which one you will suggest is the best one to start with for?
Which one uses what?
Out of these three.
Well, which one do I use out of all three? I use them all, but I use a lot of CJC 1295, I would say, and PT 141. But I have 15 other peptides I use in my office. So I don't want to overwhelm you with all the peptides.
So you keep changing?
Yeah, I always change. Okay. I mean, I try newer and newer peptides. I'm a peptide junkie. So.
Okay, that explains it. And the other thing I wanted to ask is, does the state board monitors these kind of prescriptions for non-HIV patients?
I'm sorry, it's hard to hear the echo.
Does the state board monitors writing of these prescriptions in non-HIV patients?
I don't know if they do. I think this is kind of new stuff for them, but I would write a prescription for each patient, and a reliable compound pharmacy will need that prescription with their address and their phone number, so that at least you log it. And so the thing is that these are really. We have almost 300,000 peptides in our body. We're just basically enhancing our body to basically turn on the signaling method to basically do what it's supposed to do. So anyway, I don't want to take more time for. Sure.
Can you just give a brief comment on the cost of a lot of these things? Because, for example, growth hormone, as you said,
sure.
Very expensive. Just to give me a minute.
Okay, the question is the cost of CJC 1295. I tell my patients it averages about $240 a month versus, you can pay up $1,500 to $2,000 a month. So it all depends on how much growth hormone you're using. But so it's very affordable for a lot of my patients, not for everyone. But it comes in a 10-week course, so it's like $600 or something like that for the patient, so retailed. So anyway, that's kind of the ballpark price. All right. I'm sure if you have any other questions, you can meet me out in the hallway. Thank you very much.
Thank you. That was great as usual.